Improving healthcare for the deaf community through better accessibility and cultural competence. The deaf and hard of hearing are a population with a distinct and rich culture that is often overlooked by the healthcare community. Deaf individuals have unique language, culture, and healthcare needs. Let's start out by defining some terms, specifically deaf with a lowercase d versus capital Deaf D. Deaf with a lowercase d is any hearing loss that makes spoken language difficult. Most deaf people lose hearing later in life. They view their hearing loss as a disability. They grieve for their hearing loss, and they tend to prefer English because it was their first language. On the other hand, deaf with a capital D refers to individuals who are culturally deaf and consider themselves to be a part of the deaf community. Most of these individuals have lost their hearing in early childhood. They do not necessarily view their hearing loss as a disability. American Sign Language is their preferred language over English, and they have a distinct deaf culture. And yes, you heard correctly, American Sign Language, known as ASL, is not English. It is a complete language all its own, with different grammar, syntax, and words. It is a visual language, and interpreting is not word for word, but is instead concept-based. Some 35 million individuals in the U.S. have some degree of hearing loss. However, of this number, only about 600,000 self-report as culturally deaf. Unfortunately, we really don't know how many deaf people live in the state of Alabama because Alabama only publishes limited data on the number of deaf people in the state. The United States Census does collect information on the number of Americans who speak a language other than English at home. However, the census does not identify American Sign Language as a language other than English. The cultural identity and perspective of the deaf community has been shaped by historical events. In particular, the deaf community struggles against ableism, or discrimination against those with a disability, and autism, the belief that hearing people and spoken languages are inherently superior to deaf people and sign languages. These discriminatory beliefs and practices were systematically encoded into education and healthcare in the U.S. for nearly a century through the acceptance of a movement known as oralism. Oralism labeled sign language as inferior and forbade its use among the deaf. This deprived thousands of children of early language acquisition through forced lip reading and vocalization. Deaf children frequently fell behind their hearing peers in school, and educators would label deaf children as mentally retarded and segregated them from the general population. Hearing educators violated deaf autonomy by dictating how deaf children would be educated without any input from the deaf community. Hearing medical doctors frequently made decisions for their deaf patients. Many believed that deaf individuals should not reproduce. Treatments were performed without informed consent, and in the worst cases, deaf individuals underwent forced sterilization and institutionalization. These practices continued until the early 1960s, when a linguist named William Stokoe convinced educators that ASL is a true language and that oralism was fundamentally flawed and harmful. Important accessibility legislation began being passed in the 1970s, which culminated with the Americans with Disabilities Act, or ADA, of 1990. The ADA was the landmark legislation prohibiting discrimination based on disability. It's the law that provides reasonable accommodations to employees, students, and healthcare patients and requires universal accessibility in public programs. Today, deaf individuals in Alabama are represented by the Alabama Department of Rehabilitation Services Board. The ADRS Board represents Alabamians with disabilities at the state level. The board includes 7 members, 1 from each congressional district, 3 of whom must have a disability, and 1 of whom must be the parent of a child with a disability. Like all Alabamians, deaf individuals are represented in U.S. Congress by senators and representatives. Deaf individuals are also represented in Congress by the Congressional Deaf Caucus, a bipartisan caucus that promotes equal access to government for the deaf. The deaf community represented by this project live in the Birmingham-Hoover-Talladega CSA, a combined statistical area, which is a term used by the U.S. Census Bureau to describe a metropolitan and micropolitan statistical area connected by social and economic relationships. Here is some basic demographic information on the Birmingham-Hoover-Talladega CSA. The top 5 chronic diseases in this area are heart disease, cancer, stroke, diabetes, and arthritis. The National Association of the Deaf has published a position statement defining appropriate policy for healthcare workers when caring for deaf and hard of hearing patients. The guidelines include clearly identifying patients at risk for poor communication, the use of visual medical aids, providers learning basic sign language, establishing an effective communication office policy for addressing needs, providing qualified sign language interpreters, and avoiding ineffective communication methods such as lip reading and note writing. The American Public Health Association's Achieving Health Equity in the United States policy recommends more intentional, comprehensive, system-oriented, and coordinated strategies to achieve health equity in the United States. Provision 1 of the American Nurses Association Code of Ethics dictates that the nurse must practice respect for human dignity, establish relationships of trust with patients, and defend every patient's right to self-determination. Every patient has the right to determine what happens to their own body and to make decisions after being given accurate, complete, and understandable information in their preferred language. This leads to the primary issue of concern: language and cultural barriers in healthcare. Healthcare communication should always be presented in the patient's native language, and the ADA requires that all healthcare providers provide interpreter services. However, many healthcare providers do not understand that ASL and English are not interchangeable, that many deaf patients have poor written English literacy, that deaf culture exists and should be respected, and that providing an interpreter is their responsibility under the ADA. Deaf and hard of hearing patients are at a higher risk for high cholesterol, diabetes, heart disease, obesity, and suicide. They are at higher risk for misunderstanding diagnoses and treatment instructions, and they are known to have poorer health literacy. Healthy People 2030 includes many goals that are relevant to the deaf and hard of hearing population. Some of these include increasing the proportion of adults with hearing loss who use a hearing aid, increasing the proportion of infants who did not pass their hearing screening to get evaluated for hearing loss by 3 months of age, to increase the proportion of national surveys with questions to identify people with disabilities, to increase overall health literacy, to decrease the proportion of adults who report poor patient and provider communication, and to continue development of objectives related to sensory and communication disorders. The APHN can promote Healthy People 2030 through the 5 sub-roles, including, as clinician, they can assess the needs of local deaf communities and create programs to address national and community goals. As researcher, the APHN can support research on deaf demographics and data on deaf people of color and ethnic minorities. As educator, the APHN can develop programs to educate both deaf patients and their providers on language accessibility requirements, health literacy, and deaf culture. As collaborator consultant, the APHN can create policies that fund state and local organizations that provide resources for deaf people. And as advocate change agent, the APHN can advocate for equitable care, autonomy, and the rights of deaf patients in healthcare. For this project, a review of literature was performed on the following databases and keywords, limiting articles to within the last 5 years. The literature review revealed the following key themes: extensive barriers to deaf patients existing worldwide, that there is a need for better education among healthcare professionals regarding communication barriers, ADA requirements, and deaf culture, and that advocacy education for deaf patients, their families, and their providers is needed. Here is a sampling of 3 articles that demonstrate the key themes identified. Evidence-based primary prevention efforts for deafness include genetic screening and prevention of infectious diseases through methods such as vaccination, hygienic measures, and vector eradication. Secondary prevention efforts include early screening for infants and children, including early sign language access for children with hearing deficits, and otitis media treatment, which can limit hearing damage caused by ear infections. Tertiary prevention efforts for mediating deaf disparities include access to ASL interpretation, education for healthcare providers, self-advocacy training for deaf patients, and health education provided in ASL. Deaf individuals have their own distinct culture that exists within the same environment as their hearing peers. However, they may feel alienated in the hearing world. They lack basic healthcare resources in their native language. They lack access to preventative care, and deaf individuals in rural areas, those with limited financial resources, and those with other health comorbidities are at an even higher risk of marginalization. Some prevention interventions within the APHN sub-roles include the creation of programs to educate healthcare professionals on accessibility and cultural needs of deaf clients, the completion of more research on the demographics of the deaf population, educating the deaf and hard of hearing population to improve overall health literacy, advocating for strong policies for deaf care at the local, state, and national levels, and advocating for culturally sensitive care and education among healthcare professionals. The theoretical framework for this project is Dorothy Orum's theory of self-care deficit, which states that self-care is a function that all people must perform or receive from others to maintain life, health, development, and well-being. Self-care deficit refers to the relationship between the capabilities of the patient and their care demands, and nurse systems are produced by nurses for individuals or groups with similar therapeutic demands. As part of the needs assessment, a windshield survey was conducted in Talladega County. This survey revealed overall limited healthcare resources in the county. However, there are some resources for deaf and hard of hearing individuals provided by the Alabama Institute for the Deaf and Blind and the Alabama Department of Vocational Rehab. 2 key informants were also interviewed. The first key informant, KM, is a deaf educator at the Alabama School for the Deaf. She feels that there are disparities in healthcare access for deaf individuals due to a lack of understanding of ADA requirements and an ignorance of deaf culture by healthcare professionals. She believes that more education for healthcare professionals is needed in these areas. The second key informant was Dr. W., a hearing physician in Central Alabama. He believes that there is a lack of adequate training for healthcare professionals on ADA compliance and deaf cultural competency. He would support formal training in these areas for himself and his staff. Overall, the needs assessment revealed needs for access to interpreters in healthcare, better communication with healthcare workers, and education resources provided in ASL. 3 community diagnoses were developed for this population as shown. The priority community diagnosis was found to be impaired therapeutic relationship between the deaf community and healthcare professionals related to communication barriers and inadequate practice of culturally competent care. Therefore, an evidence-based education plan was created to educate healthcare workers of any discipline on the basic requirements of accessible and culturally competent care of deaf and hard of hearing individuals. This program educated workers on deaf history and culture, American Sign Language and communication basics, ADA requirements, and accessibility types and cultural competency. The learning activities for this presentation included an educational presentation, PowerPoint slides, printed handouts, a video presentation, and a demo of basic medical signs in ASL with resources. After completion, learners demonstrate knowledge of ADA requirements, deaf culture, and culturally competent care, and complete a multiple-choice pre-test and post-test. Needed resources included a classroom, supplies for printing handouts, deaf participants and ASL interpreter services for video, and video camera and editing software. The project was implemented over the fall 2021 semester with a budget as indicated below. Challenges identified prior to implementation included learner engagement, scheduling, and video presentation production, including scheduling of participants and obtaining interpreter services. Team members included the staff and management at a local hospital in Birmingham, KM, the librarian and educator for ASD, deaf volunteer community members, RW, a local video and design professional, and the MSN preceptor. Key stakeholders include deaf individuals and their families in Central Alabama, faculty and staff of AIDV, and the participating hospital staff. The project was implemented on October 1st with 37 staff of different disciplines taking part. They showed excellent engagement and participation. Many reported that this was the first time they had ever received education in ADA compliance and deaf cultural awareness. The small group format was ideal for accommodating the time constraints and group size limitations of the hospital location. An ADA handout created by the author helped to facilitate learners who preferred visual and read-write learning styles. The handout emphasized the most important aspects of ADA compliance. The video presentation was an important aspect of the educational program that facilitated direct involvement from the local deaf community. It also created an emotional connection with learners that was vital for meeting effective educational goals. Finally, an ASL demo with resources was designed to appeal to kinesthetic learners and to inspire interest in learning more ASL. An unexpected advantage of this portion was that it fostered an emotional connection with the language and culture. Challenges encountered during implementation were COVID-19 restrictions, which required the original education plan location and format to be altered. One unexpected challenge was test aversion. Learners in the healthcare setting showed an unexpected aversion to formal testing. The pre-test and post-test were made optional to encourage participation. However, this means that evaluation data is incomplete. On the other hand, the informal question and answer method of evaluation was very successful. Learners in the small groups seemed engaged and felt comfortable asking thoughtful questions throughout the program. For future educational endeavors of this type, the author provides the following recommendations. 1. There is a limited amount of research available on the culturally deaf population. Acquiring enough peer-reviewed data on this population may be challenging and require more time. 2. COVID-19 restrictions. Flexibility in all areas is essential. Have alternate plans for location, time, and group size. 3. Planning and scheduling. Consider holding educational presentations on multiple days and multiple shifts to maximize participation. And 4. Learning evaluation. Learners in the healthcare setting showed an unexpected aversion to formal testing, but were open and responsive to other less formal methods of evaluation, such as question and answer during the presentation. In conclusion, there is a clear opportunity for improving healthcare for deaf individuals through basic education and advocacy. This project met its goals and is scalable to reach larger audiences. It is the author's hope that this educational project can be an inspiration for more research and education directed at improving the health and well-being of the deaf and hard of hearing population. Project references are as follows.